live stream does use the microphones, so we are going to ask commissioners to use the microphone even though we're here together. I don't know if we need that for the executive session.
You just to be able to keep up for it.
Okay.
We're live.
Welcome to all my fellow commissioners who are meeting here in person at the HPC offices and the public who is participating through the live stream today. Thank you all for attending. At the start of today's meeting, the commission is going to vote to go into executive session. So we're doing this to make the public aware that we are going into executive session, and we expect to reconvene in the open meeting, the public session again at approximately 2 o'clock. The open session will cover 3 different topics today, including the material change notices and the proposed new clinical affiliation between the Dana-Farber Cancer Institute, the Israel Deaconess Medical Center, and the Harvard Medical Faculty positions. So before we vote to go into executive session, could I ask the director's office to briefly introduce what those topics will be for those who are tuned in?
Great. Good afternoon, everyone. Good afternoon, commissioners. As Chair DeVoe just laid out, we will be first entering an executive session for approximately 1 hour. Excuse me. And then we'll be returning in public session for a number of agenda items focused on our market oversight authority. So first, we will hear a presentation from Lois Johnson, our general counsel, on some new updated guidance around our material change notice process. This is the notice by which providers and other market participants notify the HPC of significant material changes to operations. We'll have a brief update on some of those changes to our guidance. We'll then hear our regular agenda item on our recently received and completed reviews of material change, and then finally turn to a continued conversation on the transaction between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and Harvard Medical Faculty Physicians. So before we move into executive session, though, we can take a vote on the minutes from the last board meeting.
Good. Thank you so much. And just note to commissioners, we're used to when we're remote having a roll call for the votes, but since we're together in person and it's a public meeting, we can avoid the roll call vote. So what I'll ask you to do is just indicate that you're ready, either aye or nay on the votes verbally, rather than doing it. So are there any amendments to the minutes from December 13th? Seeing none, could I call for a motion to vote on the minutes? And a second, please. Thank you. So could all in favor of the motion to approve the minutes indicate by saying aye? Aye. And those opposed to the motion verbally indicate nay. Hearing none, approve the minutes. We'll now take the vote to enter into confidential executive session, resuming our public meeting in about an hour.
Chair DeVoe, I've just been informed by legal counsel that we do require a roll call vote for entering into executive session. So
Okay.
We will have to ask for everyone's assent on that one.
Thank you. Absolutely. Thanks so much, Liz. Could I call for a motion to enter confidential executive session? Second. And let me ask each commissioner to vote aye or nay. Vice Chair Thorne?
Aye.
Commissioner Blakeney?
Aye.
Commissioner Castillo? Aye. Commissioner Cutler is not present. Commissioner Foley?
Aye.
Commissioner Howe? Aye. Commissioner Giovanni?
Aye.
Commissioner McGregor? Aye. Commissioner Cosner? Aye. And Commissioner Beck? Aye. Great. Thank you. We will now go into executive session. Thank you, and welcome to the public that is tuning in on YouTube. We'll now turn to the open session of the meeting. Thank you for joining us. We will have 3 agenda items to cover, and I'll turn things over to David Seltz to get us started.
Good afternoon, everyone. Good afternoon, members of the public tuning in. Our apologies for beginning this public session a little later than we had anticipated, but we are grateful for your participation and engagement in the work of the HPC, and grateful to have all of the commissioners here today in person for this important meeting. We have 3 agenda items for our business today, all focused on the HPC's authority to monitor healthcare market changes and the impact of those market changes on healthcare costs, healthcare access, quality, and health equity. First, we'll hear from legal counsel on some updates to our process for receiving notices of material changes. These are the notices which trigger HPC review, and we have some clarifying guidance for the market around when those notices should be filed with the HPC. We will then do a regular update of all of the notices that we've received since the last board meeting and any reviews that we've since closed. And most importantly, we will be discussing today a proposed transaction, a clinical affiliation between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and Harvard Medical Faculty Physicians. This is a significant proposed new transaction, and so we will walk through some of the details of what we know of this transaction and put before the board a decision about whether a full cost and market impact review is warranted on this transaction. So diving right in, I'm going to turn it over to Lois Johnson to discuss the updates on our material change guidance.
Thank you, David, and nice to see all the commissioners in person. As David said, this is an update on 2 new guidance documents that we released this month regarding the MCN review process. These FAQs, as we call them, frequently asked questions, are posted on our website and have been shared with our email listserv. So we always encourage market participants and their counsel to contact the HPC directly if they have questions about, in a particular case, whether an MCN notice is required, and many do so, and we are grateful for that. But based on those questions, we frequently use these FAQs from time to time to provide guidance to a wider audience about the application of our regulation. So it's not a change to our regulation, but rather it's an amplification and clarification. So the first of these 2 FAQs addresses situations in which an MCN may be required when entities propose transactions involving management services organizations, the sale of non-clinical assets of a provider organization, and indirect control. And so we are clarifying who must file in certain circumstances and the types of transactions that must be noticed. So often a key question is whether an acquiring party is a provider organization under our regulation and therefore needs to file a notice. So the FAQ clarifies that even if the management services organization, or MSO, does not directly provide healthcare services, it may be a provider organization under our regulation if the MSO represents or provides legal, administrative, or other supports to providers negotiating contracts with payers, then they're a provider organization. That includes messenger model type arrangements. And for types of transaction, the FAQ also clarifies that an affiliation may require an MCN, and even in cases where the entity doesn't technically buy the provider, but rather acquires the non-clinical assets and or obtains indirect control of the provider. So one example of an MCN that we received was in 2022 involving an MSO called Spire. That was an MSO which acquired the non-clinical assets of Sports Medicine North Shore and the Orthopedic ASC of North Shore. So the MSO is contracting on behalf of the ASC. Another example of this type of transaction or affiliation is Optum acquiring Atrius and Reliant. So there, Optum, through two separate MSOs, acquired the non-clinical assets of Reliant and then later Atrius. The provider entities themselves were not directly acquired. And in that case, Optum obtained the right to appoint board members of both Reliant and the Atrius boards. That's the indirect control. Next slide. And the next FAQ addresses questions that we've received about how net patient service revenue, or NPSR, should be counted for purposes of our regulation, which has a $25 million NPSR threshold for when a provider organization is required to file a notice. The FAQ clarifies that when counting NPSR, an entity should include all of the revenue of its highest corporate parent and all affiliates, both corporate and contracting. So what we're trying to clarify here is that for purposes of counting NPSR for the filing requirement, the entity should include the revenue of any affiliated provider or provider organization that the parent represents in payer contracting. So that would include, for example, revenue of physician practices that an MSO represents in contracting, even if that entity, that MSO, doesn't directly own those provider organizations or isn't a signatory. And the type of examples of that type of model might be something like a physician organization like MCIPA, which contracts on behalf of independent providers, isn't a signatory, but we would count that NPSR of that organization. So hopefully these clarifications are helpful to the market. And of course, in future, we encourage parties and their counsel to continue to reach out to us. You never know the different types of permutations and different types of models, but we want when parties are planning future transactions to sort of know about these requirements and certainly call upon us as a resource. Right. Happy to take any questions.
Any questions or discussion? Thank you.
Great. Thank you, Lois. We're going to move right into the next agenda item, which is our regular update on notice of material change, and happy to turn it over to Kathy Mick from the HPC team.
Thank you, David. Good afternoon, commissioners. Good afternoon, everyone. I am going to review our notice of material change updates, and or most of them, and then I'm going to hand it over to Kate Scarborough-Mills to speak to one notice in particular. As you know, this slide shows a summary of the notices that the HPC has received. You can see that since 2013, we have received notice of 163 provider transactions. And of these, transactions involving the formation of contracting entities are the most frequent. Next slide, please. Since our last board meeting in December, the HPC has elected not to proceed to a cost and market impact review on two related provider transactions that involve entities affiliated with Beth Israel Lahey Health, or BILH. The first is a proposed reorganization by the Beth Israel Lahey Health Performance Network, or BILPN, of several of its legacy contracting entities. And the second is a proposed affiliation between MCIPA and Physician Performance LLC, which is the component of BILPN that contracts on behalf of BILH-affiliated independent physician practices. In our preliminary examination of these changes, we found limited potential for impacts on spending and market dynamics. The changes that were proposed align with BILH's stated plans at the time of its formation to consolidate its contracting organizations. The HPC analyzed the potential impacts of the currently proposed changes in our prior cost and market impact review of that BILH merger, and we do not expect the changes to impact market leverage in ways that are not already explored in that CMIR. Next slide, please. Okay, and then currently the HPC is reviewing material change notice filings for 6 proposed transactions, most of which were under review at the time of the last board meeting in December. These are, first, the proposed acquisition of Amedisys, which is a for-profit home health, palliative care, and hospice company that operates approximately 19 locations in Massachusetts at the current time by United Health Group. Second, the proposed acquisition of certain outreach laboratory assets of Bay State Medical Center by the Laboratory Corporation of America, or LabCorp, as well as LabCorp's proposed establishment and operation of a clinical laboratory in Holyoke. Third, a proposed joint venture between the Greater Springfield Surgery Center and Mercy Medical Center, through which a new physician-owned company would share ownership of the surgery center with Mercy. Fourth, a proposed joint venture between Atrius and Shields to own and operate a clinic providing PET CT services in the Dedham area. And fifth, which we have received since that last board meeting, a proposed joint venture between Shields and UMass Memorial Health Harrington to manage and integrate MRI services at Harrington's hospital campus in Southbridge and at an off-campus location in Charlton. We look forward to updating you on these 5 notices once we've concluded our preliminary review. And to discuss the 6th material change, I am going to turn it over to Kate.
Can I ask just one question before?
Absolutely.
One of the things I really always appreciate the slide of like all the transactions since 2013. One of the things that we keep seeing, right, is the number of transactions that involve for-profits. And I'm wondering if there's a way for us to better track so we can see how many of these transactions are going to a for-profit entity, or it's a transition from a not-for-profit service to a for-profit service. Because I think it's hidden in these numbers, and I think we all have serious concerns about the growth of for-profit in our entire healthcare delivery system, and just be able to see that number and something that we're tracking as a commission, I think would be really important.
Thank you for that feedback. We can absolutely add that.
Yeah, along those same lines, there's certain names that we keep seeing come up. I don't think I need to spell them out, but my concern is that when do we reach a tipping point and we see that Shields is everywhere, or other groups are everywhere. And I think, so we're looking at these individually and their cost impact, and maybe we need to be looking at a more macro view and see what the impact is.
Right, it's like the services that are being provided in hospitals are slowly being privatized.
Exactly.
LabCorp is another one.
Yeah.
Have we ever, I think we did at one point, analyze all of this coming together and what the impact has been since 2013? Did we once do that? I don't remember.
In terms of,
all of these changes that have taken place and what that overall impact has been. We're looking at them individually, but when you combine them,
right,
what has the impact been?
Yeah, that's a great point, Commissioner Mastrogiovanni. I think we've tackled it in some ways, in different ways. We've certainly kind of tracked increasing consolidation of healthcare into the major systems. I think a good example of something we did recently was the pediatric report that we issued last year, where we really looked at all of the pediatric changes that we had been noticed and that had been noticed to the Department of Public Health over a number of years, and kind of built together a more comprehensive view of how the delivery of pediatric care has changed over, say, a 5-10 year period of time. So I think those types of more comprehensive reviews that piece together all of these different transactions can be really valuable in kind of seeing the forest from the trees. And so I think it's a great suggestion that we should continue to do that. And maybe some of these where we're seeing the sale of some clinical services or ancillary services, you've seen increasing trends, and it'd be nice maybe to aggregate some of that. So we'll take that on.
So you're going to aggregate the data on disaggregation.
That's a worthy endeavor.
Exactly.
All right, well, we're going to move on to the final agenda item for our meeting today, which is the review of the transaction as I identified before. Before I turn it over to Kate Scarborough Mills to just walk through what we know about the proposed transactions with BidMIC and Dana-Farber, I will note that we are here today to consider whether to move this transaction forward to a full cost and market impact review. For each of these notices, all 168 of these notices that we've received over the years, the HPC conducts a preliminary review in order to understand whether we think they're likely to have a significant impact on healthcare costs or on market functioning. And when the board decides that a transaction is likely to have that significant impact, we can advance that review to a full cost and market impact review. While that cost and market impact review is underway, the transaction cannot be completed. And it is only at a time after an issuance of our public report, which may be referred to the Attorney General or to other enforcing agencies, could a transaction close. We have conducted a number of cost and market impact reviews over the years. In each of these cases, I believe that these reports have tremendously added to the public understanding of the potential impacts of these transactions. And as a result, other enforcing agencies, such as the Department of Public Health and the Attorney General's office, have put in place conditions in some cases where warranted in order to protect against potential harms and to maximize the potential positive impacts of some of these transactions. This is a significant vote for the board to advance a transaction to a cost and market impact review. I would note it has been a number of years since the board has made a decision to advance a transaction to this stage of review. Beth Israel, the combination of Beth Israel and Leahy Health System was the last cost and market impact review conducted by the Health Policy Commission. So Kate will walk through some facts about what we understand for this transaction, and then we will open it up for a discussion about whether this transaction warrants that deeper, comprehensive public review. Off to you, Kate.
Great. Thank you, David. Next slide, please. So as noted, we are obviously recommending further action on the proposed clinical affiliation between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty Physicians at BIDMIC to offer oncology services in Boston in the Longwood medical area, anchored by a new Dana-Farber Cancer Hospital that would be adjacent to and connected to BIDMIC. My colleague Sasha Hizresnov provided a high-level overview of the proposed affiliation at our December meeting, so I will fully acknowledge that some of this will be a bit of a review, but I wanted to provide a bit more information as we've continued to learn about the proposed plan, as well as our recommendation for further review, and some background on the CMIR process itself, recognizing that we have some newer commissioners who this may be their first CMIR. And we will start with Dana-Farber. Thank you. As you all know, Dana-Farber Cancer Institute is a nonprofit acute care cancer hospital as well as a research institute. It is fully independent, neither a corporate nor contracting affiliate of any other provider system in Massachusetts, and it is the only National Cancer Institute designated comprehensive cancer center in the Commonwealth. Dana-Farber currently provides outpatient care at its hospital main campus and a number of licensed hospital satellites, with 97% of its volume by charges being in the outpatient space currently. For inpatient care, Dana-Farber has had a clinical affiliation with Brigham and Women's Hospital since 1997. Dana-Farber currently has 30 beds on its own hospital license, but those beds are located in and leased from Brigham and Women's Hospital. And in addition, the Dana-Farber physicians provide medical oncology services currently to Brigham and Women inpatients in other Brigham and Women beds. In addition to that longstanding affiliation with Brigham and Women's, Dana-Farber has a broad network of affiliations with other provider organizations in Massachusetts. For example, it provides services at and through affiliations with South Shore Hospital, Milford Regional Medical Center, St. Elizabeth Medical Center, Whittier Street Health Center, and it also runs the Dana-Farber Cancer Care Collaborative, which provides consulting, educational, and clinical support services, things like second opinion services, tumor board conferences, lectures, to multiple additional provider organizations in New England, including Berkshire Health Center, UMass Memorial Healthcare, and Cape Cod Healthcare. Based on the information that is reported into our Registration of Provider Organizations program here at the HPC, Dana-Farber has the largest number of oncologists in its physician network out of all of the Massachusetts provider systems, approximately a third of all of the state's oncologists, and Mass General Brigham, its current clinical affiliate, is the second largest, so with approximately a quarter of the oncologists in the state. If we go to the next slide, you're all obviously familiar with BIDMIC, the 809-bed academic medical center that acts as one of the anchor hospitals for the Beth Israel Lahey system. BIDMIC is the largest of those 10 Beth Israel Lahey hospitals, and Harvard Medical faculty physicians at BIDMIC, which we will fondly call HMFP, is the physician group that employs the physicians that staff BIDMIC and the other BILH facilities and community hospitals around Boston. Particularly relevant to this transaction, both BIDMIC and HMFP currently do provide cancer care services. BILH has the third largest number of oncologists in the state, with approximately 11% of the state's oncologists in its network, behind Dana-Farber and MGB. Next slide, please. As we reviewed at the December board meeting, the current clinical affiliation between Dana-Farber and Brigham will run until at least 2028. And at its conclusion, Dana-Farber, BIDMIC, and HMFP have proposed an alternative clinical affiliation. The parties filed an MCN outlining their plans with the HPC late last year. And in connection with the clinical affiliation, Dana-Farber plans to construct a new freestanding cancer hospital adjacent to BIDMIC on the current site of the Joslin Diabetes Center. As you see here, the proposed cancer hospital would have 300 beds, 300 inpatient beds, 20 observation beds, and significant new imaging and therapy equipment. The project is under review by the Department of Public Health's Determination of Need program as well. That DON application was recently deemed complete on January 8th and is available publicly on the Determination of Need website. Under the affiliation, Dana-Farber would remain corporately independent and would continue to contract separately from BIDMIC and HMFP. However, the parties would collaborate to provide adult cancer services at the new facility and the Greater Longwood medical area, with each taking responsibility for certain elements of oncology care. You see a summary of who's doing what in this proposed affiliation. So the short version is that BIDMIC and HMFP would serve as the preferred providers for surgical oncology. Dana-Farber would be the preferred provider for medical oncology and infusion. HMFP would provide the clinical cancer pathology, clinical cancer radiology, and certain other physician services to Dana-Farber. They would have physician leaders that would have dual roles at Dana-Farber and BIDMIC. And then Dana-Farber and BIDMIC would work together to coordinate radiation therapy, with the technical part being done through a joint venture and the professional part being done through a jointly formed provider organization. And BILH would provide Dana-Farber access to its EHR system. This next slide simply summarizes a lot of that information and should look familiar, as I believe we showed the same slide at our last meeting. The left side summarizes what we know about the cancer hospital, including the breakdown of the 320 beds and the advanced imaging units. And the right side summarizes those clinical collaborations I just described. Obviously, we're still in the process of learning all of the details of the parties' plans, but I'll pause here in case there are any factual questions on what they're proposing before we go on to the parties' claims on the potential impacts.
Who's funding the new facility?
Dana-Farber is the applicant to the Determination of Need program, and so it will be a Dana-Farber owned hospital. Certainly there is intended to be a lot of collaboration, and there is going to be a number of pieces of this that will be done through BIDMIC as well, but the hospital itself will be a Dana-Farber hospital.
Who owns the land?
So currently, this is Jocelyn's diabetes center currently, but they do have an arrangement. All right, on the next slide.
We have one other.
Yes.
Okay, I'm sorry. Looking at the timeframe
Yes.
and realizing how many regulatory steps go into this process, what do we know of the plans if the 2028 date is not attainable?
I do believe that MGB and Dana-Farber are in discussions.
And a second question, I don't know that it's in our purview, But somebody needs to ask the question of where are the nurses coming from?
We'll add that to our list.
Okay, thank you.
On this next slide, you see their own, the parties' key transaction claims. So they have claimed that this affiliation will impact healthcare spending, market functioning, quality, and access to care in the key following ways. First, parties claim that the affiliation would not have a material impact on reimbursement rates because BIDMIC and HMFP would continue to contract with payers independently from Dana-Farber. However, they do expect that some cancer care would shift from higher priced systems and providers, notably MGB, to relatively lower priced Dana-Farber and BILH providers. And in the DON application, Dana-Farber claims that the proposed cancer hospital would have a pro-competitive effect on the market for oncology services. The parties also claim that the collaboration would increase the quality and efficiency of oncology services by combining the parties' respective cancer expertise in interconnected facilities, all of which would be consolidated into this single hospital, as well as through measures such as integrated clinical protocols and EHR and electronic health records, as well as required adherence to certain performance and quality standards. The parties also claim that the collaboration would increase access to high-quality tertiary and quaternary adult oncology services for the highest acuity patients with the most complex diagnoses, and Dana-Farber's DON applications outlines its assessment of a growing need for more sophisticated oncology services in the coming years, and claims that the proposed new cancer hospital would help meet that anticipated need. Dana-Farber also acknowledged in their DON application the racial disparities in cancer mortality. And as part of that application, they note a goal to expand access in particular for at-risk, historically marginalized, and diverse populations.
I'm sorry, before you proceed again, in an earlier slide, you mentioned that 97% of the hospital's care being provided on an outpatient basis. I know that they have outlier clinics all over the Metro Boston and Eastern Massachusetts. What of the outpatient care currently being done through Brigham's, through their outpatient center, and will they match or exceed their outpatient resources on the new site?
That is certainly an area that we would look into in a CMIR, but not an area that we would have the answer to at this stage.
Okay, thank you.
You know, I had a question sort of along this similar line, just given our conversations about site neutral payments and really the promise of that for containing costs in the state. The prospect of an entirely new hospital being built, especially around cancer care, which was actually one area that the guest speaker from Brookings spoke on in, I think it was September, as one area that's significantly more expensive in hospital departments versus in other settings. And I'm not familiar with the landscape of cancer care in Massachusetts particularly, but just a recommendation that, you know, we would look into the extent to which it is very much hospital centric. It sounds like it probably is. I wonder if there's a way to move away from that in this transaction.
Great. That's also another area that we're happy to look into. And I will note that one of the topics that they highlight in their DON application is that the hospital would be particularly helpful for the more complex cases that do require inpatient treatment. So there is a little bit of a focus on those more complex cases for this, but we will certainly look into that. Are there any further questions before I? All right. So as a reminder, the statutory standard for when the HPC may move review of a material change notice to a full cost of market impact review is when a transaction is anticipated to have a significant impact on the Commonwealth's ability to meet the healthcare cost growth benchmark or on the competitive market. Our assessment is that the proposed transaction is likely to have a very significant impact on the market for oncology services in Massachusetts. with likely impacts on healthcare cost, quality, access, and equity, as the parties also acknowledged as we went over in the last slide. We've detailed our key reasoning here. So first, the change in Dana-Farber's key AMC affiliation from Brigham to BIDMIC could obviously have substantial impacts on the competitive market for adult cancer services, as Dana-Farber is the only NCI-designated comprehensive cancer center in the Commonwealth. It has the largest network of oncologists. It has numerous affiliations with other providers in Massachusetts, and this would replace a 25-year clinical relationship with the hospital system with the second largest number of oncologists. It would then affiliate it with the hospital system with the third largest number of oncologists. And these shifting relationships are likely to significantly impact how and where patients receive oncology care in Massachusetts, as well as how the market functions for those services. Second, the affiliation incorporates a plan to add 270 inpatient beds as well as the 20 observation beds in downtown Boston to Dana-Farber's current 30. This is a substantial increase in capacity that is also likely to result in significant impacts on the market for oncology, as well as substantial changes in the mix of providers that patients use for inpatient oncology care. Third, the proposed transaction is also likely to impact healthcare spending, as patients are likely to shift among providers with different price levels. The affiliation may also impact providers' bargaining leverage with commercial insurers, which may impact prices and other contract terms that impact spending. It may also impact other aspects of pricing. Medicare pricing, for example, is different for cancer hospitals as compared to other hospitals. And the affiliation may impact total utilization in the service mix of cancer services as well. Finally, these shifting relationships and the construction of a new freestanding cancer hospital, as well as other aspects of the party's proposed affiliation, are likely to impact equitable patient access to oncology services in the state. A cost and market impact review would allow the HPC to examine all aspects of the transaction to better understand each of these impacts, and then publicly report on those potential impacts on cost, market functioning, quality, care delivery, and access and equity. So this slide just briefly goes over what a CMIR is, what it is not. This may be reviewed for some, but a CMIR is really a process that's intended to provide greater transparency, including through a detailed public report. There's an opportunity for the parties to publicly respond to our findings, and it's an opportunity for accountability and for the parties to address any concerns about potential negative impacts, as well as an opportunity to enhance potential positive outcomes from any potential transaction. A CMIR report can also be an input into other oversight processes. CMIR reports, as you know, have been used by the Attorney General and the Department of Public Health's DON program, as well as other regulators. I do want to clarify, though, that our CMIRs are obviously also distinct from those DON reviews, as well as antitrust and other law enforcement reviews, which each have their own specific criteria for review. And the next slide goes through the factors for review in a CMIR. So these are our factors laid out in our regulation, which we may evaluate in conducting cost and market impact reviews, and these are also derived from the statute. As you see here, we look rigorously across a number of factors related to healthcare costs and market functioning, quality, access, and equity. And importantly, one statutory factor is other factors in the public interest. And so this really provides us with a fair bit of flexibility to tailor our review to the facts of a specific transaction. And it also represents an opportunity for our commissioners to identify particular areas of inquiry that they'd like us to engage in a given review. These factors do include some of the types of issues that might come up in other types of reviews, like antitrust enforcement or the determination of need program, but are also somewhat broader than those reviews. They're really intended to allow us to present a comprehensive view of the potential impacts across many different domains. On the next slide, as you know, we've developed a broad slate of analytic and qualitative tools to address those factors, and we build on and adapt those tools in each one of our reviews. To inform our reviews, we make use of publicly available data, such as the invaluable data sets from CHIA, as well as the critically important information that's submitted to the Department of Public Health, the Determination of Need program. And we also have the ability to solicit information directly from parties, from payers, from other providers, and from other stakeholders. And we have the authority to keep sensitive information confidential to help inform our review while protecting the privacy interest of our stakeholders as well. We're fortunate to have the support and feedback of various experts. Of course, we have all of you, our expert commissioners, but also the expertise of our internal HPC teams, as well as contracted teams of economists, actuaries, clinical consultants, financial experts, and others. And as you see on the right side of this, the outputs, at the end of the process, we write a preliminary report. Parties have an opportunity to respond to that report, and then we issue a final report, which incorporates that response and any additional work, any additional analyses that we may do to address issues raised by the parties. The transaction, as a reminder, may not close until 30 days after a final CMIR report is issued. And our reports can include referrals to other state agencies or the Attorney General's office as appropriate. The next slide, we reviewed this timeline in December, highlighting the key points along the process. But as a reminder, a CMIR takes 185 days from a completed material change notice, which here we expect those materials to be completed imminently. However, I will note that the timeline is usually extended as parties often require more than the 21 days provided by statute to respond to information requests. And I'll note that the 185 days also reflects the timing for a final report because we give parties 30 days to respond to a preliminary report before issuing that. Practically, that preliminary report is often 60 days or so prior to that 185-day timeline.
And I'll just add on this particular timeline for commissioners, throughout this process that staff is conducting this review and gathering this information, we stay in regular contact with all of you, provide you updates along the way. When we want to meet with you and solicit early on what are the areas that you would think are most important for us to review. You've given us some feedback already today. You will have additional opportunities to provide that to us as we develop the preliminary report. So there will be multiple touch points with commissioners throughout this process, some appropriately in the public space, some appropriately confidentially, depending on the material that we're reviewing.
Great. And this next slide similarly is just a reminder that the determination of need review process will be going on at the same time on a somewhat different timeline. That normally takes 6 months, but it does have the potential for further extension if the Department of Public Health requires the applicant to produce what's called an independent cost analysis. That's a determination that they will have to make in the coming weeks. That is really intended to document whether a project will meaningfully contribute to the Commonwealth's goals for cost containment, improved public health outcomes, and delivery system transformation. And it is generally done by a third party and paid for by the applicant. It is a separate process for the CMIR process. I will note that in the past, that is a process that has only been used in times where we haven't also had a concurrent review. So it is a little bit of a novel situation here where if that is something that moves forward. At the end of the DON review, staff issue a report on whether the project meets the DON factors for approval, and they can recommend conditions on the project that may be necessary to meet those factors. And as Sasha detailed at the last meeting, the DON regulations do contemplate a situation where determination of need review is happening at the same time as a cost of market impact review, and the determination of need doesn't go into effect until our process is done, even if the DON process ends first. And with that, I will pause. That was a lot of information. So if there are questions on the process, how we do our process here, the DON process, or factual questions about the transaction, happy to take those. And of course, I want to open it up for discussion.
On the increased beds, and forgive me if this was discussed in December, I just blocked it out. Have they given a reason as to why they are doing such a large expansion? Are they expecting more out-of-state patients or things like that?
Yeah, so their determination of need application includes a fair bit about their projections for increased demand. A lot of it is driven by an expectation that there will be an increase in cancer incidence as the population ages. There's also, they also cite changes in the clinical standards around cancer care, and that there are certain therapies like CAR T therapy that really require inpatient treatment. So it's a combination of demographic changes, trends that we've been seeing in cancer, as well as changes in treatment modalities.
Will it include any pediatric or no? Is that contemplated?
My understanding is that it is focused on adult oncology, but that is certainly something we can run down further.
I would just pick up on Barbara's point. I think we're looking at investment in a major cancer facility in Boston. What's the implications in the rest of the state? I know currently there are other affiliations across the state, but what happens to those? And thinking back to our pediatric report where we talked about what that means to have that concentration in the Boston area as opposed to the rest of the state, just thinking about that as we do this review. The second, as I've read articles about this affiliation, people point to Sloan Kettering, the Anderson in Houston. If maybe we had a sense of what current cancer care looks like in major metropolitan areas across the country to understand what 300 beds means versus what is currently being provided, that would be helpful.
That's great, thank you.
Other questions or discussion?
A question and also a clarification, please. The part of the process that you said would allow us to assess whether or not this expansion would improve public health outcomes, is that the public hearing at DPH discretion, or would that be something that the HPC would be involved in?
So that is part of one of the DON factors that has to be met for approval of a determination of need application.
Okay.
So it is something that the Department of Public Health explicitly has to consider. Obviously,
Right.
Our factors are broad enough that it could be part of our analysis as well.
Okay, makes sense. Because, as much as this is clearly something that's going to meet the need as disease patterns change, tragically, actually, in the population, I mean, I'm sure we've all been seeing the news on under 50 cancer rates, and it's very tragic and heartbreaking. And I know many of us are, and our loved ones are personally impacted by this. There's something that is still a little bit concerning, or a lot concerning, about a brand new hospital coming into being to sort of meet this need. And from a consumer advocacy and sort of public interest standpoint, I wonder if there's a way to require that Dana-Farber and this new entity also invests in prevention at some point, or the preventive aspect of it, because we're seeing these 30-year-olds and 40-year-olds getting colorectal cancer diagnoses and breast cancer diagnoses at all stages and advanced stages. And we can build a hospital to provide chemotherapy and treatment, which that is dreadful in and of itself, although it could be life-saving. But what about the prevention side? And then another potential suggestion on the equity piece is around payer mix. So I don't know if you have a sense of what Dana-Farber's current payer mix looks like. But if there's a way to require a certain and very specific payer mix for this new entity, that could be a way to sort of explicitly hold them accountable to the statement that they made around equity.
Yep, That's very helpful. And I will say that there is payer mix information in their determination of need filing, which is public. The majority of their patients are Medicare patients, over 50% are Medicare. But I do not recall the Medicaid percentage off the top of my head.
I think we're all eager to jump ahead to what we want you to look at, well, until we vote for this cost of market impact review, but just on the equity piece as well, also the workforce, the goals for the hiring of the workforce. Clearly, it's an RN issue, but it's a direct care workforce issue. It take more than one job title to do this work, and making sure that that workforce is reflective of the patient population that we hope has access to these services if this were to go through.
Other questions or discussion or comments by? If not, yes.
Yeah, I agree with, with Tim. I too am jumping ahead to what yeah, but I think to take the point one step further about the workforce, we have a lot of people in the immediate Metro Boston area who would be superb working in these types of jobs, and I sure would like to see some commitment to hiring as much locally and within the neighborhood as possible. Folks that live in that area deserve a shot at these jobs if they like them.
Thank you.
Thank you. Good.
Madam Chair, can I make a motion to move forward with a full cost of market review?
Second.
Thank you. Thank you. And let me, any other discussion on the motion? And let me move to ask for commissioners to vote, and we'll do so orally by indicating either aye or nay. Can I first ask that all those in favor of the motion indicate by saying aye?
Aye.
And then all those opposed to the motion, could you indicate by saying nay? We have unanimous support to move forward on this very important work, and I think you can tell that we're all looking forward to seeing the data information and beginning to answer the key questions that you've raised, which are such an important responsibility for the HPC.
Thank you, commissioners. I do believe that this work is in the public interest to have this transparency on potential impacts. We look forward to conducting this review with your expert consultation and a lot of work ahead. Thank you.
Terrific. Well, that concludes our agenda for today. I want to thank my fellow commissioners for their time and coming in to meet in person this afternoon, and also to give the schedule of our upcoming meetings. Our next public meeting will be the committee meetings, both market oversight and transparency and care delivery transformation, on Thursday, February 15th. And as a reminder, our committee meetings will now begin at noon. Any other final comments before we close? Thank you all, and thank you for those who have tuned in.